Hi, this is Elliot Fishman, and welcome to part 4 of our intense look at hepatic masses. And last time we mentioned hepatic adenomas, and we said we'd look into it in more detail. Well, hepatic adenomas are a very, very important lesion. They're more common in women, average age around 40. There's a long-term relationship between oral contraceptive use and hepatic adenomas, usually more than a couple years. In the male patients, there's increased risk with anabolic androgen steroid intake, as well as metabolic liver diseases such as glycogen storage disease, tyrosinemia, steatohepatitis, and hemochromatosis. The one that typically we think about surely with multiple hepatic adenomas, particularly in a younger patient, is glycogen storage disease. Most hepatic adenomas are solitary, but I will admit we seem to be seeing more multiple lesions lately. Perhaps it's due to better techniques. Again, multiple lesions are common in patients with glycogen storage disease or liver adenomatosis. Size range, I would say the average is about 5, but the range is 1 to 15 centimeters. The larger lesions and patients with multiple lesions are more prone to bleeding. And the problem with hepatic adenomas, there are a number of subtypes, but they can develop into hepatoma. And the reality is, as I'll show you, many hepatic adenomas are extremely difficult to distinguish from hepatoma. The most critical finding often is that there's no cirrhosis present. Now, when you describe hepatic adenomas on CT, not always, but they're typically a well-defined mass that can contain hemorrhage, necrosis, fat, or occasionally calcification. I think most of the cases with calcification is because the patient previously bled. On non-contrast scans, they're typically hypo or isodense. On arterial phase imaging, there's moderate enhancement. On portal phase imaging, the lesions enhance similar to surrounding liver. They can become nearly isodense with the liver, but they don't do it in a way that's similar to FNH. FNH really becomes isodense very quickly. The hepatic adenomas are less dramatic as they wash out, but still easy to see on venous and delayed phase imaging. But they can become very similar to background liver. We'll look at some examples. Here's about a 3-centimeter lesion right lobe of the liver. Now, the patient has no cirrhosis. You can see some prominent vascularity, particularly on the MIP image. And I have to admit, you would look at this image and you would say, this could definitely be a hepatoma. There's a vessel leading into it, but those multiple small vessels always worry me. And that's why the challenge of hepatic adenoma exists, because this lesion easily could be a hepatoma. Here's a few more views showing it. You can see on the venous phase, it washes out a bit, but there it is. Like hepatomas, they could have a pseudocapsule. You can see it there. And they also could have a central scar. Remember, I mentioned that central scars were classic, at least way back when I wrote the article, for FNH, but the truth is central scars are common in hepatic adenomas. You can see them in hepatomas and cholangiocarcinomas and in everything else. Another case, very similar though larger, there's a vascular lesion with poorly defined margins near the dome of the liver. You can see the prominent vascularity on the coronal and on the MIP imaging. And you look at this lesion, it's not the enhancement of hemangioma. It's not the homogeneous enhancement of FNH. This is something where you think about hepatic adenoma, but you're also thinking about hepatoma. On the venous phase imaging, you can see the lesion stands out again. It's very concerning. Here it is on the cinematic rendering as well. And that was hepatic adenoma. Another case, here there's a dominant mass centrally in the liver as well as a second lesion in the right lobe posteriorly. Poor borders, again, one of the things about FNH, sharp borders. In their own way, hemangiomas have sharp borders, cysts have sharp borders. Hepatomas can have pseudocapsule, but typically poor borders. Same thing for cholangio, and same thing for hepatic adenoma. It's very difficult to define the border here, and you see the blush, you see the neovascularity. You really have to worry this is going to be a hepatoma. The lesion on venous phase is less well defined, but you can still see it. This could be a hepatoma with washout. Again, a very challenging diagnosis. You could use MR with contrast. They may be helpful in select cases, or you may need to do a biopsy. This is a tough lesion to resect because it's so centrally located. In patients with multiple hepatic adenomas, because of the risk of malignancy and the inability to resect all the lesions, some patients may actually get liver transplants. Here's another patient. Again, this same patient we just looked at, but again, comparing the arterial to the venous, we worried about hepatoma. This was hepatic adenoma, as I mentioned. Now, sometimes hepatic adenomas are more subtle and infiltrating. Look at the enhancement of the left lobe of the liver. It's kind of a regular enhancement, right? It's not like a discrete mass in some sense. It looks a little bit more dominant as a mass when you look at the coronal views. You can see some of the splaying of the left hepatic artery. Again, infiltrating tumor. Again, thinking about malignancy in this case. Stretching of the left hepatic artery. When you look at the late phase imaging, the lesion becomes essentially isodense. You can still see the mass, but it's nearly isodense to the remaining liver. And this was eventually biopsied and resected. This was hepatic adenoma. It's interesting, the textural changes are accentuated by the cinematic rendering, and one of the things cinematic rendering does is give good texture mapping, which is nicely shown here and here as well. Another patient. Here's a patient with multiple small vascular lesions in the liver. You could say metastatic neuroendocrine tumor. You could say multiple hemangiomas, though it doesn't look like that. There's fatty infiltration of the liver. We do see increased incidence of hepatic adenomas with fatty infiltration, and these are multiple small vascular lesions. When I do the MIP imaging from venous phase, look how many lesions I see. Again, if the patient had a neuroendocrine tumor, that would be a real possibility. This ended up being multifocal hepatic adenomas. Remember, we said the majority are solitary. There aren't that many cases that have so many lesions, and it can be a real challenge because, again, I would not have considered, that these are FNHs. Obviously, they can be multiple, but not so many. Too many hemangiomas. I'm thinking metastatic disease. As you get later phase, you can see the lesions. They're not as well defined. But here they are on the cinematic rendering. A very, very unusual case of hepatic adenomas and one of the challenging cases. Again, multiple lesions, vascular. Think about metastatic disease, neuroendocrine tumor, renal cell carcinoma, but also think about hepatic adenoma. A really nice case. And again, another example of multiple hepatic adenomas. Again, the cases where we see multiple hepatic adenomas, you almost always see fatty liver. Now, what about this case? Large mass, very vascular, and washes out. The liver is not cirrhotic, but I have to admit my first thought here is hepatoma. It's hard to get around hepatoma with such a vascular mass. If the patient's younger, you might have said fibrolamellar hepatoma, but this mass has what appears to be neovascularity, prominent enhancement. I'm thinking HCC. You can see as the lesion washes out, it's still well defined with what looks like in part a pseudocapsule, but still very, very nicely defined. And that was hepatic adenoma. And again, the comment that it may be difficult to distinguish hepatic adenomas from hepatoma based strictly on CT criteria is indeed very important to remember. And let me just show you a few more cases, because I think one of the important things we do with these lectures is show you a lot of examples. I don't get up here and show you one or two cases like it's a textbook. I want to show you the spectrum of disease so you really can appreciate it. Here's a well-defined mass in a cirrhotic liver. When you show me a cirrhotic liver, I'm always thinking about hepatoma. There's the mass on venous phase imaging. It has what I would call a pseudocapsule. It has central scarring in the center of the lesion. It's washing out, but again, I still am favoring or highly suspicious for a hepatoma. There's some prominent vascularity present, which again supports my diagnosis of hepatoma. But this was focal nodular hyperplasia as a consideration. But for some reason, that's how it was read. But this is not FNH, right? Because it doesn't have the homogeneous enhancement. Yes, you have some vessels. Yes, there's a central scar. But this is in the differential of hepatoma and then perhaps hepatic adenoma or even metastasis like melanoma. Again, on the venous phase, the pseudocapsule, the well-defined lesion, a really nice example of the challenges of distinguishing hepatic adenoma from hepatoma. This was hepatic adenoma, just a really, really great case. And this patient did have a history after biopsy of glycogen storage disease. So, it can be very difficult. Now, in looking at the patient's pathology a lot closer, the lesion was read as hepatic adenoma, and then there was some comment that it was perhaps pre-malignant for hepatoma. So the final path and the way the patient was treated with resection was that could this be a hepatoma arising in a hepatic adenoma in a patient with glycogen storage disease. But again, the initial report, and the patient had been followed for a number of years with hepatic adenoma. What about this case? Multiple lesions in the liver, vascular, in a 30-ish-year-old male. Again, it doesn't have the look of hemangioma, no peripheral puddling. Could it be FNH? It's sort of bright. Remember I said FNH is as bright as the IVC, not the aorta? This case looks as bright as the aorta. So I don't like this case for FNH. You can go and look more carefully at the lesions. They tend to wash out a bit as you look at later phase imaging. But again, the prominent vascularity centrally. Again, you can see how valuable MIP imaging is in this case. And again, the thought, could this be hepatoma? Possibly. Multifocal hepatoma. Could this be hepatic adenomas? Here's the washout. You can see it looks like marked textural changes in the liver. The patient has underlying parenchymal liver disease, which would surely push you to the thought the patient could have hepatoma. This was biopsied, eventually resected, the left lobe lesion, and was hepatic adenoma. Another example. Now remember I said that one of the classic things about hepatic adenomas is they bleed. If you ask the question, what's the most common liver lesion to bleed spontaneously? The answer is either hepatoma or hepatic adenoma. If you see a spontaneous bleed in a liver lesion, the challenge is you often can't find the dominant mass because there's so much blood present, as in this case. You can see the vessels are stretched, there's blood and a large mass. It's hard to define the borders of the mass because of the blood, but this was hepatic adenoma with spontaneous bleeding. Another patient, right upper quadrant pain, it was thought to be acute cholecystitis or pancreatitis, but there's a large mass or mass effect in the liver by the dome, splaying of the hepatic artery, blood present. Again, this is the differential diagnosis of a tumor that bled, hepatoma, hepatic adenoma, occasionally FNH, occasionally hemangioma, occasionally metastatic disease like for melanoma. But look at the splaying of the hepatic artery, the mass effect. It would be very hard to determine where the tumor is. Is this a 5 centimeter mass or a 2 centimeter mass because there's so much blood present? Invariably, they'll follow this patient, maybe get an MR, and then eventually resect the lesion or biopsy it depending on the findings as the hematoma resolves. You can see the large hematoma very nicely on the cinematic rendering. Here it is both on the volume rendering, venous phase, and cinematic rendering, and that was hepatic adenoma that bled. Another case, acute abdomen, bleed right lobe of liver and subcapsular blood. Again, you could say hepatic adenoma or hepatoma, and just to keep you honest, this was a neuroendocrine tumor. Metastatic neuroendocrine tumors, metastatic melanoma, are tumors that can have spontaneous bleeding in the liver. And this is just a nice example. But again, if you told me this was hepatoma, or you told me this was a hepatic adenoma, it would be hard for me to disagree with you. Now, when you look carefully at this case, you do see on venous phase multiple additional liver lesions. Now, you could have multifocal hepatoma, unlikely multifocal hepatic adenomas, though I did show you one case a little bit ago. But when you see multifocal disease, then it probably pushes you a little more to thinking about metastatic disease. Of course, if the patient had neuroendocrine tumor, perhaps you would find that tumor, be it in the pancreas or be it in the small bowel. So just a really nice example here of spontaneously bleeding from a metastatic neuroendocrine tumor. In this article by Thomas, a broad spectrum of pathologic conditions can present as spontaneous hemorrhage within or surrounding the liver and can present acutely or as a chronic or incidental finding. Again, differential hepatoma, hepatic adenoma, other tumors that we mentioned, HELLP syndrome in the postpartum state, occasionally amyloidosis, connective tissue diseases because they have vasculitis, and vasculitis can lead to bleeding. That's true particularly in polyarthritis nodosa and SLE, and theoretically infectious disease like typhoid fever and malaria, though I have to admit, I haven't read a case, nor have I ever seen a case. Again, Thomas makes the point, the highest risk tumors are large and within the periphery of the liver, either abutting or protruding beyond the capsule. So that becomes a helpful sign. But again, once the lesion bleeds, it may be hard to see the patient's tumor. The cause of hemorrhage in hepatomas is usually multifactorial and not completely understood. Rupture may be facilitated by tumor angiogenesis. This leads to increasing proportion of its vascular supply by new unpaired hepatic arteries with diminishing contribution from the venous system. Microinjuries and elastin deposition in these small arteries may predispose to hemorrhage. That's a really interesting reason why, but I think no one really knows why certain tumors will bleed. There are really no good imaging features, and there are really no good lab features. Now, one of the things about bleeding, of course, patients present with acute abdomen. It's rare for us to get a requisition that says rule out spontaneous hepatic bleed. It's typically acute cholecystitis, acute pancreatitis, acute diverticulitis. A beautiful example of a cirrhotic liver, large mass right lobe, tumor extends into the portal vein, but spontaneous rupture with blood around the liver and in the abdominal cavity. Here it's easy to call it a hepatoma, not just the neovascularity and the large mass, but the invasion of portal vein. And yes, metastatic disease can involve the portal vein, but that's much less common. And again, the MIP imaging, which is very important, really nicely shows you the extensive neovascularity that is present. And here we go to venous phase, the large mass growing through and rupturing through the capsule of the liver, very nicely shown, and shown as well on the cinematic rendering here. And again, the spectrum of involvement. In this case, I think I read it as hepatoma. We all would read it as hepatoma because a large mass that bled, but you have a cirrhotic liver with invasion of the portal vein. Putting all that together works well. This was a patient who had a mass that bled. The final path was a hepatoma developing in a hepatic adenoma. So again, sometimes you get both answers. Neovascularity, stretching of the vessel. You can see the mass and the sites of bleeding on the venous phase imaging, the areas of tumor necrosis, the areas secondary to blood. One of the things you would always look for with bleeding is pseudoaneurysms of the hepatic artery, but you will see neovascularity from hepatoma, but you typically do not see pseudoaneurysms. And just a few more images very nicely showing you the venous phase of the patient's tumor. Another patient, acute abdomen, drop in hemoglobin, large mass, left lobe of liver, bleeding centrally, large hemoperitoneum, large mass. Yes, this could be hepatoma. Yes, this could be hepatic adenoma, but it could be other tumors. I would even consider a sarcoma of the liver. Those sarcomas are very rare. Maybe something like an angiosarcoma. The spleen looks okay. But look at the bleeding, the active bleeding within the tumor. Again, you kind of know you're in the malignant category. And the question is, what is giving you this active bleeding? Look at the active blood seen as you go to venous phase imaging. This patient was embolized and eventually this tumor was resected. Well, what are we dealing with? Large bleed, large hemoperitoneum. This was metastatic melanoma. So again, going through that differential diagnosis, I mentioned melanoma, I mentioned neuroendocrine tumors can all cause bleeding. This was a very impressive melanoma. It's unusual even for melanoma to get this large, and spontaneous bleeding does occur in very large tumors, but especially in metastatic melanoma. Another case, right upper quadrant pain, marked irregularity of the liver texture. There's blood in the liver, there's blood around the liver, there's subcapsular blood. Is this a tumor? No, the patient did not have trauma. No, the patient did not have a biopsy. The appearance you can see is that of a mass, and the mass bled. There's abnormal vascularity present. Again, going through that same differential, hepatoma, hepatic adenoma, metastasis. This was eventually worked up and was actually due to the fact the patient was postpartum, and this was a liver bleed with infarction. Now, I show this case, and I just want to back up the images one time for you to look at. One of the things that you could notice in this case is the uterus is enlarged, which is a postpartum uterus. On the initial presentation, it was mentioned that the patient was postpartum by about 10 days or so, but no one really paid attention to that because the liver was so much more impressive. And HELLP syndrome is something that's uncommon. It's a life-threatening condition that occurs in under 1% of pregnancies, typically develops in patients with severe preeclampsia, and usually manifests between 32 to 34 weeks of gestation. However, up to 1/3 of cases occur in the postpartum period, usually within 48 hours of delivery. But other cases can occur 7 to 10 days later, and there's increased morbidity and mortality. And again, postpartum hemorrhage is a leading cause of maternal mortality. You got to think about this possibility. When you do CTs in the postpartum period, you're always looking for bleeding in the abdominal wall, in the uterus. You're worrying about uterine rupture. You're worrying about retained placenta or other foreign matter. But you got to be thinking and make sure you look carefully at the liver. And it's a very unusual cause. And again, this review of postpartum complications is worth reading because none of us see all that many complications, but it's a critical diagnosis. So, imaging of non-traumatic hemorrhagic hepatic lesions by CTisus. It's an older article, but some things don't change. Most common causes of non-traumatic hepatic hemorrhage are hepatoma and hepatic adenoma. Again, the differential diagnosis, metastatic disease, FNH, hemangioma, and unusual conditions like vasculitis and HELLP syndrome. And again, think about this HELP syndrome. Again, it's always at the bottom of the list, but in the right clinical history, it should move to the top of the list. Now, we spoke a lot about hepatic adenoma and how hepatic adenomas can become hepatomas, how it's difficult to make the diagnosis, that it's challenging the overlap, how both can present with bleeding. And what I want to do now is look at hepatoma a little bit more closely. And I know we've had a lot of time in this lecture, so let's take a break here and come back in a few minutes and discuss hepatoma. See you then. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.